Chapter 10, Part 2. This is a list of the equipment we would need for a routine venipuncture. So we have our gloves, vacutainer holder as seen here, our 21 or 22 gauge needle, microtainer tubes if we're doing a capillary collection, vacutainer test tubes, butterfly needle, tourniquet, and our sharps container. Again, this is just some phlebotomy supplies. We need the alcohol, tape, gauze, the other thing to bandage or Coflex, depending upon the type of patient we're working with. And we will go over this in detail in class as well. Again, this is devices and things we might need in our supplies for venipuncture. We're going to tie our tourniquet and palpate or feel for a vein. And just please be aware, typical veins of the arm, our median cubital vein, which is our first choice, our cephalic vein, which is second, and basilic is last. Again, remember that the cephalic is located on the thumb side, basilic's pinky, and median cubital is right in the middle. And then the hand veins, we have the dorsal venous network, which is anything below the wrist bone is acceptable for venipuncture in the hands. This kind of just goes over images and gives you typical veins of the arm, but also seeing variations. We might have patients that have more arm hair than others, and others too that the veins are more visible. And again, this goes over first, second, and third choice for vein selection for phlebotomy. We will not be drawing from the dorsal backside of the hand. And the other thing to take into consideration when we're drawing here, again, we want to go below the wrist bone. We do not use arm veins in these conditions, IV lines in both arms, burn scarred areas or edematous arms, arms with a hematoma, if there's a cast on the arm, thrombus veins, partial or radical mastectomy on one or both sides. In a lot of these circumstances, we would have to get a doctor's order to draw potentially from a foot, but that is the doctor's call and not ours. Making veins more predominant, we're going to use the tourniquet, position the arm downward and relax, use gravity to fill the veins, warm the site if applicable, assist in vein location, and it causes veins to fill with blood. It enables easier blood flow after needle insertion, and it's a single use. Ask the patient to extend his or her arm fully. You want to gauge it based on what the patient can do, not necessarily based on you forcing it. Okay, most procedures call for gloving prior to venipuncture. However, others allow for vein selection with the healthcare worker's clean index finger followed by hand washing and gloving. So you can do either system. We're going to stretch both ends of the tourniquet around the arm about 3 to 4 inches above the puncture site, and we're going to tuck the section next to the skin to make a partial loop with the tourniquet. Okay, this is what's called a quick release, and we will have a detailed lab on this going forward. We're going to stretch the ends of the tourniquet around the patient's arm about 2 to 4 inches, palpate to find the best vein, tight but not painful, and we keep the tourniquet on no longer than 1 minute. Tourniquet release. Release it after the needle puncture when blood has begun to flow into the collection tubes. During venipuncture, release tourniquet with one hand. The other hand will be holding the needle and tubes. Figure 10/29 here. Once released, the tourniquet can remain loosely on the arm or surface work area until the procedure is completed. We're going to clean the site with alcohol in concentric circles from the inside out. Remember to cleanse the site again if you touch the site with any non-sterile material and allow the site to air dry. Choosing a venipuncture method, we're going to consider patient factors and practices at each facility. The evacuated tube system with single-use safety needle is the most common and the most economical. I will go over the different types of needles in class and the situations we would use those needles based on patient factors. So again, greet, assess, and identify your patient. We're going to assemble supplies and check the expiration dates and integrity of the needles and tubes. We're going to apply the tourniquet, select the most suitable vein. What is the vein selection order in the antecubital area of the arm? I will have you review this. I will be reviewing this slide again in class. We also are going to cleanse our hands and position the arm downward but slightly bent. And this is just an image of what I was just talking about. Offer to answer any questions during the procedure. Prepare all supplies according to manufacturers, and we prepare our supplies in front of the patient so that they know they're clean, new equipment. Do not touch or blow on the site after cleansing it. And we're going to caution the patient that he or she will feel a stick. We're never going to say you're going to feel a small stick because the patient might react differently. The other thing too is we're going to let them know it's going to happen ahead of time, so we prepare the patient as well. You're going to position the needle so it's oriented the same direction of the vein, and it is slightly 30 degrees or less with the skin surface. With the bevel side up, you're going to insert the needle quickly. A slight pop should be felt as you enter the vein. We're going to anchor with our thumb of the opposite hand 1 to 2 inches below the puncture site, and this is to keep the vein steady. While keeping the needle assembly stable in the vein, we're going to center the first collection tube in the holder and gently push it onto the holder. And we're going to use the flange pieces here to help guide that tube in. As the tube is pushed into the holder, the inner needle punctures the diaphragm of the closure and blood should begin to flow into the test tube. At that point, we're going to release our tourniquet. If blood does not flow, palpate gently above the puncture site to feel for the vein and possibly redirect the needle slightly. We do not probe. Hold the needle very steady. Carefully push the evacuate tube into the holder so that blood can enter, and we will show you this in class. As the blood begins to flow, instruct the patient to open the fist and release the tourniquet. Or orient the tube in a downward position to avoid possibility of backflow of additives into the patient, which can cause adverse reactions. Watch carefully to see when blood flow ceases. If multiple sample tubes are to be collected, remove each tube with the holder with a gentle twist and pull motion and replace it with the next tube. Again, we're going to be utilizing the flanges on the needle holder to help with this process. When all tubes have been filled and we remove the needle, remove the tourniquet. If it has not already been done, we're going to withdraw the needle and then place gauze. We will show you this in detail in class as well. Gently press the gauze over the site to control bleeding. Apply pressure and ask the patient to hold gauze until bleeding is stopped. We're going to activate the safety device, which is seen here, according to manufacturer's instructions. This may involve resheathing, covering the needle once it has been withdrawn. We're never going to recap. You're going to discard the needle device in the appropriate container as one unit, so the tube holder and the needle go together. We never separate it, bend it, or break it to pull it apart. Remember, do not shake the tubes. Remember to gently invert mixed tubes that contain additives. A complete inversion means turning the filled tube upside down, then returning to upright position 5 to 8 times. Apply pressure until bleeding is stopped, and then we're going to lift the gauze up to check that bleeding has stopped prior to bandaging our patient. If patient's present, we're going to label the specimens appropriately using the pre-printed labels and handwritten ones. We will be handwriting out all our labels in class. Ask the patient to confirm identity on the labeled specimen by checking the labels and thank the patient for cooperating. Also, too, we're going to double check with our patient and see if they need anything else. Is there anything else I can get for you before I leave? The wean infusion method, or the butterfly safety method, it's commonly used for our pediatric geriatric patients, patients having numerous needle sticks, patients in restrictive positions, and patients with small veins in the wrist or hand. We also will use this system on patients who are severely burned, fragile skin or veins, and patient request is the most common one in short-term infusion therapy or temporary IVs. We're going to check the dorsal side of the hand for suitable vein. Note that the hand veins are smaller and may roll more easily than veins in the incubital area of the arm. If a hand is made into a relaxed fist, the veins are slightly more taut and stable, but it does not eliminate the need to anchor that vein. When the site is selected, apply the tourniquet. We're going to cleanse the site with isopropyl alcohol. And if the hand is in a relaxed fist position, again, the veins are slightly more taut and stable. We're going to hold the needle by the wings, and the wings on this device are referred to here, and we're going to go back a slide. To get closer and more precision insertion point, we're going to insert the needle at a slight angle, 15 degrees or less for butterfly. Again, for the regular venipuncture needle, it's 30 degrees or less. After the needle's in the vein, the blood should begin to fill the tubing. In class, we instruct you not to let go of the butterfly needle, and we'll explain that more in class. We're going to release the tourniquet if it's been more than 1 minute. After the needle is in the vein, the blood should begin to fill the tubing, and the evacuated specimen tube can be gently pushed into the barrel, and you will see a return of blood that goes down the line and into the test tube. We're going to activate the safety device immediately after withdrawing the needle. This is a push button, so this little black dot is a push button that retracts the needle prior to coming out of the patient. We also have a different system we'll show you in class. Following remaining steps for assuring bleeding stop, bandaging, labeling, as I explained in the previous slides. Special considerations when we operate with a butterfly needle set. The tubing contains air. It will underfill the first evacuated tube by 0.5 mL, thus affecting the additive to blood ratio. So it's essential when we draw a light blue top tube, we fill a red top, no additive tube prior to any tube with additive to avoid that tube potentially being underfilled. After the first tube, the order of draw should be the same. We use a discard tube for that specific reason, and I will talk about this more in class. Syringe method rationale not routinely used due to safety issues, cross-contamination of additives in multiple tubes, and use of excessive force to withdraw the blood. I do show you this method in class though. Can be useful in special circumstances, especially when we have veins that potentially collapse easily, and blood withdrawal can be gently controlled. I will have you review these slides as I will show you a detailed demonstration, and we will be performing these in lab as well. This is the blood transfer device that we would use to transfer blood from a syringe into our test tube. We will not be piercing the top of the test tube as that is a bloodborne pathogen exposure risk. Order of draw. This will be covered in great detail in class, but this is the mnemonic we're going to use. Stop light red, stay put, green light go. I will have you review this slide on your own. Like I said, I will be providing a great detailed overview of this in class. The bottom piece here goes in order, lists the additive that could potentially be in the tubes listed above. Considerations when filling tubes, we have additive carryover. Additive anticoagulant in one tube should not come in contact with the multi-sample needle as the tubes are changed. Avoiding carryover by gently tapping tubes to remove additives to the bottom tube prior to using them, and this is why we have an order of draw as well. We're going to hold the tube downward during blood collection. Specimen identification labeling. The label should include the patient's first and last name, unique ID number, and or date of birth, date and time of collection, the type of sample collected, specimen type, PHB's initials, and the test or analysis that was performed. Specimen identification labeling. Ensure that all information is complete and correct. If possible, ask the patient to confirm the info on the label tube. We never pre-label. And document the situation if unable to obtain a specimen. Disposal of used supplies and equipment. I will have you review this on your own. Other issues affecting venipuncture practice. I will have you review these as I will go over this in class. Reducing hematoma complications. Insert the needle at the correct angle through the upper vein wall, but not through the lower vein wall. We're going to remove the tourniquet prior to removing the needle. Hold the needle device steady when changing tubes to avoid slippage of the vein. And when mixing blood in the tubes containing additives, we do not shake the tubes. Instead, we're going to gently invert them. So we're going to check for hematoma formation during and after procedure. And applying pressure is the key thing to prevent a hematoma from becoming severe. And this concludes Chapter 10, Part 2. Please view Chapter 10, Part 3 to continue with this slideshow.